Hi everyone. Hi everyone. Welcome to another global VMR. And today we are continuing our series presenting the internal medicine program, and I'm very excited to introduce the UPMC Internal Medicine program today. So we have some special guests to present a case, and then we are going to have some questions about the program and talk a little bit about this program. So first, if Thiago, who is also a SIP Solver's old friend, if you could please introduce yourself, talk a little bit about what you like to do outside of medicine, and then if you can pass the mic to another program members, please.
Good. Thank you, Marcela. So good to be here again. For a long time, I've attended VMRs almost every day. And since starting the intern year, it's my first time here. So I'm so glad being back. I'm an intern at UPMC. I'm Brazilian. As I said, this is my first year. What I like to do when I'm not working, I like to learn. So I try to learn medicine when possible. I like travel. I love travel. So because of COVID, I couldn't travel that much recently, but this is something that I love to do. And I love going out, having dinners, talking to friends. This is what I try to do outside of medicine. And so good to see faces that I don't see in a long time, like Dhruv saying hello. Hi, Dhruv, and Robbie. So good to see you again. And I'll pass it on to Matthieu, Chief President at UPMC, so he can say a little bit more about what he likes to do besides medicine.
Awesome, thanks, Thiago. So like Thiago said, I'm Matthieu Metzinger. I'm one of the two recruitment chief medical residents at UPMC, the University of Pittsburgh Medical Center in Pittsburgh, Pennsylvania, in terms of medicine stuff. So I'm going to do the General Internal Medicine Fellowship at Pittsburgh for the next 2 years, and then hoping to stay on as faculty in General Internal Medicine. And outside of medicine, some of my favorite things. I have family nearby Pittsburgh, like an hour away, so I see them a good deal. But within Pittsburgh, we have lots of really wonderful restaurants, bars, so places constantly opening up. It's nice to be able to walk from my apartment and be at some new bar or restaurant within 5 to 10 minutes. I see some Pitt undergrads. I love it. So yeah, it's a really cool city, so we can answer any questions about that towards the end, in addition to the program. And I'll pass it over to Steph, the other recruitment chief.
Hey everyone, I'm Steph Gambino, born and raised in Pittsburgh, left for a little bit for undergrad in Texas and med school in New York, and came back to be closer to home and because I love the city of Pittsburgh. Amazing city, amazing things to do outside of work. I also like to check out the new restaurant bar scene, mostly with Matthieu, and then also into triathlon sports, so running, swimming, biking, lots of stuff around here that you can do to be outdoors and active. I applied to endocrine this year for fellowship, so hoping to stick around UPMC for endocrine fellowship and then hang out in Pittsburgh for a few more years after that. Cool. And then was Haiza on? She could probably do an intro too, because she's from here.
Hi guys, I'm Haiza. I'm a third year, I was going to say third year Pitt, and my husband here is driving, this second year running. We're both from Brazil, and outside of residency, I think one of our favorite things is just doing like road trips and kind of exploring the area. We recently discovered quite a few wineries around Pittsburgh, so that's our big thing now. And I guess anything related to food, cooking, barbecues, all that. I think we enjoyed a lot. Yeah, gardening. So nice to meet everybody. And let's go to Roberto.
Okay, so do we have anyone else? Anyone else from the program? Thiago, do you know if...
I think Roberto was here, but I don't know if he's here now or if he can talk.
Okay.
Yeah, I think this is all. Oh, they are driving. Yeah.
Okay, no problem. So yeah, let's just start. So Thiago is going to present a case. We are very excited because Thiago has amazing cases. So let's go. I think Yasmin is going to, can you share your screen, please?
Can you see it?
Yeah, thank you, my friend. So Thiago, the mic is yours.
So it's a 75-year-old male present with nausea and vomiting. Do you want me to stop there or go ahead?
What do you think, Robbie?
You know, I think Tiago is clearly interested in stopping now, so let's go ahead and nerd out with him. Why don't we? Take it away, Marcella. What are your thoughts?
Okay, so nausea and vomiting, they are very unspecific. So it's kind of hard to me, but let's see. So if we go for categories, I would say, so it could be something seems to be more acute. Do you have the time, Thiago, maybe? The tempo?
Few days.
A few days. Okay, so it's sometimes more acute. Since I like ID, we can always think about an infection or even food poisoning because of a toxin or something like that. Since it is a node patient, I would be worried to first check vital signs and to understand how severe is this nausea and vomiting. If he is dehydrated, so if I need to do some treatment first and then start thinking about the DX, and then to check if he has any electrolyte disturbance or something like that. So when I also think about nausea and vomiting, we can think about something that's triggering that. So maybe it's not like the disease itself, but it's like a reflex. For example, if neuro, sometimes we have some strokes that can cause nausea and vomiting because it affects the nerve or something like that. So I think that would be my first thoughts.
I think they're absolutely superb. You know, I'm always a little bit on guard when Tiago is presenting a case because he always takes us on a journey. But if we take this as simplistic, I think the thing to pay attention to in this case is the unusual nature of the chief complaint. Nausea and vomiting are very, very common, but they're very unusual as the chief complaint. Most people with disorders of nausea and vomiting frequently lead with the accompanying symptom: abdominal pain, chest pain, headache, foot fracture. So it is very unusual for nausea and vomiting to be the chief concern. Now, that unusual nature may simply be an artifact and a distractor, and we'll hear very quickly that this patient has another accompanying, more specific symptom. But if we really believe that the nausea and vomiting is the dominant part of this patient's experience, it is a very specific differential diagnosis. And that differential diagnosis has two layers to it. The more morbid hypotheses are the patient has a lesion along the vagus nerve, specifically in the brainstem. That would cause isolated nausea and vomiting. In some patients, especially those with diabetes, they can have nausea and vomiting from acute coronary syndrome without chest pain. So brain and heart are the most important, but the most common is a proximal GI issue, upper GI tract, be it a peptic ulcer disease or gastroparesis or something like that. When Tiago is here, endocrine gets prioritized. And 2 weeks ago, Marcel and I discussed a case of nausea, vomiting predominance that turned out to be adrenal insufficiency. So endocrine is an important category here as well. So I think that in terms of categories, Marcella, I think you nailed it. The neuro and the heart are the priority. The proximal GI tract is the most common. But practically speaking, non-emergent causes like medications and toxins, so chemotherapy, for example, or cannabinoid hyperemesis syndrome are also things to think about. But I think we should remain open to the possibility that Tiago might share with us a new localizing symptom, which would completely eliminate this schema, because this is only for nausea and vomiting as the chief concern. All right, Tiago, tell us more, please.
Sure. So he also, so it was for days, okay, for a few days. He also complained of weakness, so he was able to take care of himself, but in the last few days, he was not able to take care of himself. Besides the nausea and vomiting, he was losing weight, and in the last few months, he lost 40 pounds. So he also reported some abdominal pain, and he was hospitalized a few weeks prior, and discovered to have lung nodules, liver masses, and also adrenal masses.
Okay, so I think now we have more symptoms to work with. Since we have this severe weakness and weight loss and now the masses, so I'm thinking more about cancer. And I'm thinking that maybe the nausea and vomiting, since they are the chief complaint, could it be because of a mass that is maybe pressing or something like that we didn't see yet? Or is it because, for example, lung nodules, they are causing paraneoplastic disease? So we mentioned that could be adrenal or something like that, that's causing the nausea and vomiting. And especially because now we also have adrenal masses. So that's where my thoughts are now. What do you think, Robbie?
Yeah, I completely agree with you. I think if you layer on to our existing schema, could this be a CNS issue? I think yes. Could there be a metastasis there in the brain? Could this be a heart issue? A little bit less likely now because of the dominant cancer history. Could this be a proximal GI issue? Absolutely. A proximal GI obstruction, like gastric outlet obstruction, could easily be doing this. Could this be a medication or toxin? If he has received chemotherapy for this, definitely. Could this be adrenal? Oh my gosh, absolutely. Adrenal insufficiency. In fact, if you ask yourself, what kind of adrenal insufficiency does a 75-year-old person in the United States get? And autoimmune adrenalitis is the most common, but that would be very unusual as a 75-year-old. So what rises to near the top, if not the top, is metastatic replacement of both adrenal glands, where we actually had a case on RLR maybe about a year ago. So I think that Marcela, I think we both know that we are making an assumption that these things represent cancer. That's 90% probable in the United States. But there's a small chance they represent something in your favorite world, which is a metastatic infection. So we have to make sure we're not going wrong in that domain. But in terms of analyzing the nausea and vomiting, I think what rises in probability is proximal GI obstruction and then cancer-induced adrenal insufficiency. All right, Tiago, tell us more, please.
Okay, so since you are, I'm not talking about adrenal insufficiency, but you are. So since you are talking about it, in the previous hospitalization, there is a cortisol, and the cortisol was 15.6, the hospitalization in which he was diagnosed with the masses. And the ACTH was 86. So this was in the system. For the past medical history, GERD, hypertension, hyperlipidemia. Yeah, ACTH was 86. This is correct, Yasmin. Family history, mother with hypertension and diabetes, yeah, she died, and father had heart disease. For the social history, 40 years, smoking 1 packet per day. and no alcohol. For the meds, amlodipine, statin, atorvastatin, ferrous sulfate, and venlafaxine. Do you want me to stop there or keep going?
What do you think, Robbie?
Why don't we hear what you have to say?
Okay, so now I'm thinking that just let me check. The ACTH is high and the cortisol is high. Is that correct, Thiago?
ACTH is mildly elevated. The upper normal limit is 60, so it's mildly elevated. And the cortisol, let's say less than 3, it's adrenal insufficiency. More than 15 or 18 is not adrenal insufficiency. So let's say for a cortisol of 15.6, adrenal insufficiency is very unlikely. You can advocate it's possible. So it changes the sensitivity and specificity if you change the cutoff for 15 or 18. It was in the morning, okay?
Okay.
The morning cortisol.
Okay, thank you, Thiago. So yeah, I am a little bit confused right now because we saw that the cortisol, so it's highly unlikely, like Thiago said, that's adrenal insufficiency. So I'm going first to focus on the masses. I saw that the patient has a smoking history, so I'm a bit concerned that that can be related, so an increased risk. And yeah, I'm still trying to understand the cortisol and the ACTH here because the cortisol, it's like unlikely that's adrenal insufficiency, but the ACTH is a bit elevated. So would be like the cortisol is not adequately responding to the ACTH that's higher. So I'm not sure. I'd like to know what you're thinking, Ravi.
I think you're on the right track here. I think that the best analogy to study is hypothyroidism. So if the TSH is high and the T3 and T4 are low, we say that is hypothyroidism. But if the TSH is high and the T3 and T4 are normal, one of the differential diagnoses is called subclinical hypothyroidism. And that basically is saying, in order to maintain normal levels of thyroid, you need more force from the TSH molecule. And the risk of developing overt hypothyroidism is higher in patients with subclinical compared to patients with normal thyroid axis. And so the question here is, can we say that this patient has, analogously say that this patient has subclinical adrenal insufficiency? Not that that's a term that's used, but rather for us to use creatively thinking and saying, well, why does it take more cortisol, more ACTH to maintain a normal cortisol? And the cortisol is not really that high. You know, it's like just barely above the detection of 15, our threshold. So clearly the pituitary is having to push more to maintain a normal cortisol. In most patients, you don't really pay much attention to that because the underlying cause of their adrenal insufficiency is slowly progressive. Even if it's autoimmune adrenalitis or if it's TB, the two most common causes, they don't progress over the course of weeks to months. But there are two considerations in which case the adrenal insufficiency can progress very quickly. And that's vascular causes of adrenal insufficiency with adrenal vein hemorrhage, thrombosis causing adrenal hemorrhage, and then tumor. His tumor is his tumor, like we had a case yesterday of rapidly progressive tumor. The story of a rapidly progressive tumor replacing the adrenals very quickly, initially progressing from subclinical to then overt adrenal insufficiency, is a very reasonable thread to hold here. So I think we now have three things we need to analyze. We have this presumed cancer, DDX infection. We have nausea and vomiting, for which anything is possible, but we have one clue, and that one clue is the adrenals are not perfect and they are already involved in this disease process. So has this disease process gotten much worse? I think is a very fair line of thinking. All right, Tiago, enlighten us on what happened and what you did.
So for the physical exam, vital signs, temperature 36.2 Celsius, heart rate 58, sats 98%, blood pressure 140/80. So blood pressure 140/80. So he was cachectic, frail, BMI was 17, and he was alerted and oriented. And would say pretty much normal. He had generalized weakness, but no gross focal signs, and pretty unremarkable for the physical exam. For the labs, so the most important thing for the physical exam is that is frail, BMI 17. So he's sick. For the labs, WBC 5.6, hemoglobin 10.4, platelets 402, sodium 128, potassium 4.4, chloride 95, BUN 22, creatinine 1.5, glucose 110, calcium 9.7, magnesium 1.9, phosphorus 3.1, AST 28, ALT 13, TBD 0.3, alkphos 208, bicarb 21.4. Bicarb 21.4. Yeah, so the initial labs are there. And just for you to know, after having the labs, he was unresponsive while in the bathroom. He regained consciousness once he lay down, and his heart rate was in the 70s, and the systolic blood pressure in the 110s when he was on the ground, but he lost consciousness. I think it's a good time to stop.
Okay, thank you, Thiago. So I can see that he's anemic. So maybe it's like related to chronic disease. He has this metastases, but also worried if it could be something else. He has this hyponatremia, so it could be, we were thinking about the adrenal insufficiency. I'm thinking that maybe could be related to that. And he also has like these clinical signs that weight loss, he's cachectic, and also now we see that he has this very low blood pressure. So first we need to stabilize the patient. So very worried with him right now. And yeah, I think those are my first thoughts now, Robbie.
Yeah, I completely agree with you. It's hard not to worry about the fact that he seems like he had a syncopal event, because the fact that he improved with lying down with increased perfusion of the brain makes seizure and hypoglycemia less likely. And you know, Marcelo, the interesting thing about his vitals is that when you first look at his initial blood pressure, 140/80, you're like, oh, you know, that doesn't seem like he is very hypotensive. You wouldn't predict somebody to have a syncope from starting with blood pressure 140/80. But then you remember that he has hypertension and wonder what is his baseline. Is 140/80 lower than his baseline? And that kind of line of thinking gets some support by seeing that his systolic is even lower, 30 points lower when he's on the ground. So you initially say, look at that blood pressure, and you also watch Tiago emphasize it initially. So you're like, maybe not adrenal insufficiency, but then you see that he has a syncopal event. And in the context of cancer, the most common reason why people have pre-syncope or syncope is they're dehydrated and not eating good, and his BMI is 17, right? So that's very easy to invoke. The case for hemorrhage is not obvious, even though his hemoglobin is low, because there's no GI blood loss and no external blood loss. It's also important to entertain cardiogenic causes of syncope in patients with cancer, with the most important thing being, does he have a malignant pericardial effusion? But that was not seen on the prior imaging, but maybe it developed very quickly. So we have to think about that. But in general, syncope in general, the vascular tone is usually because of medications. And he has medications here, amlodipine, that might be contributing to it. But another cause for reduced vascular tone is adrenal insufficiency, because cortisol is actually what increases the alpha receptors in the vessels for epinephrine and norepinephrine to work on. And the pearl about adrenal insufficiency is it usually causes orthostasis by blood pressure and not so much by heart rate. So if you look, he's so sick that he's passing out, and yet his heart rate is only 70. That might be another clue to consider adrenal insufficiency, along with the sodium. The most likely cause of the sodium is hypovolemic hyponatremia, in which case he will have features consistent with appropriate ADH, namely a low urine sodium and a high urine osm. He, however, if he has features suggestive of SIADH, then you might worry about adrenal insufficiency some more. But it actually gets a little bit confusing with primary adrenal insufficiency, because some patients may also have features of appropriate ADH in primary adrenal insufficiency. So it can get a little bit confusing. But either way, now we have to worry about this patient because he's on the bathroom floor pre-syncopal. So hydration, EKG, make sure he doesn't have a pericardial effusion. And I think retesting the adrenal axis, given his adrenal mets, is important. All right, Tiago, enlighten us, please.
Yeah, so it was easy to stabilize him. So he was feeling good again when he was lying down. And yeah, a lot of tests were done at this moment, including ACTH steam test, as you said. Urine sodium, everything was done. So, you know, the time it gets back is different, but let me tell you, urine sodium is 60. Urine osmolarity is 515. Cortisol in the steam test, baseline is 10.9. Then it's 10.9 after 30 minutes and 12.5 after 1 hour. ACTH baseline was 259. And aldosterone was less than 1, undetectably low. So this is the results of the tests that you mentioned.
Okay, so I can see that now we have a low cortisol, right? And also aldosterone is low. So now I'm more worried that we are having, like, for example, the tumor compressing and we don't have the right production of cortisol or maybe aldosterone too. Yeah, that's where I am now. I lost the osmolarity in the urine. Robbie, can you help me here?
Yeah, the urine osmolarity, I think, is high. It was 500 something. How do you interpret that?
515.
515. How do you interpret that, Marcela? What does that mean to you?
So if the osmolarity is high, it means that he's able to concentrate his urine, right? So I don't think that he's probably producing more ADH. So he's like his urine is very concentrated.
Exactly right. Exactly right. And then what do you make of the urine sodium?
So the urine sodium, is it high or low? Sorry, I don't remember.
High. No
It's
problem.
high.
Yeah.
It's high. So it makes that it makes me think that he doesn't have aldosterone. So that's why he's not reabsorbing sodium. So that's why the sodium is going down. And at the same time, since he has a lot of ADH, he's getting more water. So that's why the hyponatremia.
Superb. I think you can take these tests and say he has SIADH, and the differential diagnosis includes adrenal insufficiency. And then you prove that he has adrenal insufficiency by the fact that you see that his cortisol does not go above 15 or 20 with ACH stimulation. And then the question is, what is the lesion? Does he have primary, secondary, or tertiary? And you see that his ACTH is high, which means that his pituitary is 100% okay. And therefore, this is very consistent with primary adrenal insufficiency, which is even further supported by the fact that aldosterone, which is not made anywhere else except the adrenal glands, is also low. So yeah, I think that there's many humbling lessons in this case, especially about relying too much on tests early on that can change. But I think you can diagnose him with primary adrenal insufficiency, presumably from a metastatic malignancy, but you have to make sure that there isn't TB or histoplasmosis in the background that can fool you. What were you thinking, Tiago?
So after this diagnosis of adrenal insufficiency, and I completely agree with you, Rabi, as always, this is very interesting because it developed in a short time. We have the imaging, so another set of imaging. So there are large bilateral necrotic adrenal gland masses measuring 9.7 by 7.8 in the right side and 6.5 by 3.7 in the left side. Also, there are, let me see if you find it here, but there is a small low attenuation lesion in the liver measuring up to 1.6 centimeter, and lung nodules measuring up to 0.8 centimeters. So that's the imaging that we have, and then after that I have the final diagnosis in the next part.
Okay.
Marcelo, would love your thinking. Can I just clarify one thing? Tiago, so he only has one lesion in his liver, but he has many nodules in his lung. Is that correct? Okay, perfect.
Yes.
Perfect. All right, let's hear some Marcelo wisdom.
Oh, so right now I'm thinking that we have like this high concern that is this necrotic adrenal gland mass that is causing the adrenal insufficiency and everything else. And so now we need to think about the etiology of all those tumors. So like Rabi was mentioning, he has only one lesion in the liver. So could it be the primary site of this maybe cancer? But I know also that lung cancer can have metastases on the adrenal gland or melanoma, if I don't mistake. And so I think it could also be the etiology. And like Habi said, we can also be worried about granulomatous disease. But since he's in the US, I would be more worried about a cancer history. He has smoking as a risk factor, but just have that like TB or endemic mycosis just in your back, just in case.
I completely agree, Marcelo. I think there's so much to learn about how to analyze the radiology. It's like literally looking like how if you throw paint on the wall, if you look at the pattern of the paint, how it lands, you can see where it came from. And that's what we're trying to do. We assume that the cancer was thrown from somewhere into the rest of the body, and we have to back calculate where it came from. And there are many tools that we can use, but the simplest one is to say where is there only one thing and where is there many things? And here there's only one thing in the liver and many things everywhere else. So it's easy to say the liver is the cause. The problem with that is that you can have subradiologic disease in the liver. So you can have diffusely infiltrating cancer that you don't see. And the reason to think about that potentially is that the alk phos is elevated. Maybe that he has subradiologic infiltration. So at the end of the day, you can guess as much as you want, but you need tissue. The only times you don't need tissue is when your serum free light chain or SPEP is positive, when your PSA is very high, and some other less common things like germ cell tumors. So here you need tissue. But what could this be? This could definitely be disseminated lung cancer with mets everywhere. in a patient who smokes. But I think the intriguing possibility would be that he has cholangiocarcinoma, because the liver mass does not appear to look like HCC, and he's not does not have cirrhosis. So cholangiocarcinoma is a devastating disease that affects older adults that most people have no risk factors for. So I think the question in real life is, where do you biopsy? And that is best left to the experts. But here in this case, maybe a transbronchial biopsy may give you the answer in the least invasive way. It's always a good idea to try to biopsy a metastatic site, because then you can stage the tumor right away, as opposed to biopsying the primary site. Then you don't know what the staging is. So that's my best guess as to what we might do next. Thiago, what did you do?
So IR decided to biopsy the adrenal, which I also think it's cool, because when you have to make to distinguish between benign adenomas and malignant adrenal cortical adenocarcinoma, the FNA is not good at all. It doesn't work. But when you know it's a metastasis, as in this case, he had bilateral adrenal masses and adrenal insufficiency, all the classic for metastasis, then you can do FNA and can have the final diagnosis. And that's what they did. They biopsied the adrenal gland, and it was urothelial carcinoma. So metastasized urothelial carcinoma being followed up by oncology now.
Whoa, what an amazing case, Thiago. And we were not expecting this urothelial carcinoma, but I think it's a type of cancer that also has a high chance of metastasizing in the adrenal. Is that correct? Or yes, yeah. Thank you so much, Thiago. It was an amazing case, and I learned so much. Thank you.
Marcella, it seems that every time you and I discuss, it's a case of adrenal insufficiency from something. Last time it was autoimmune. This time it's cancer. We'll see which one is next. But we should have. We're maybe a little bit biased by our most beloved endocrinologist, now general internist, Thiago, who is presenting us today. Thiago, just one question for you. In retrospect, was there any evidence of urothelial involvement on the CT, or was it not apparent on the CT?
Yes, there was. So yeah, there are several imaging. So I just described some here. And in the last one, there was a concern for prostate invasion and bladder invasion. But this last image was between the IR procedure and the final report. But yes.
I think that's so helpful, because imaging changes over time, but it's very rare to have metastatic disease to the urothelial tract. When you see a kidney tumor or bladder tumor, it's usually primary. So when you finally saw that, I think that that is very illustrative. Amazing. Well, Thiago, thank you so much for such an amazing case. I learned a lot from going through it with you, and as always, a treat to co-discuss with my adrenal insufficiency partner for life, Marcella.
Yeah, I love that. And every time I see how much I still need to study more about adrenal insufficiency, it's a never-ending journey. So thank you, everyone. And now we can discuss more about the UPMC Internal Medicine program. Please, if you have any questions, you can put in the chat. And maybe if the chief residents, they can give us a little overview about the program and what are their favorite thing about the program.
Sure. I can start us off and Steph can jump in and then we'll watch the chat. So like I said, our program's located in Pittsburgh, Pennsylvania. Association, but it's a group effort, a team effort between University of Pittsburgh and the University of Pittsburgh Medical Center, UPMC. It's a large program. Each class, we have around 51 categorical residents. And specifically of interest is we have an international scholars track. I'll let Thiago and Haiza talk a little bit more about that and answer questions with regards to that. But in terms of big picture things for our program to note, in terms of where our residents go after residency training, We have a good number who stick with general internal medicine. We have some who go into hospital medicine, and we have residents who go into just about every internal medicine subspecialty possible. Our match in terms of fellowship is a great one each year, with residents staying at UPMC and going across the country for just about every subspecialty. And we do especially well in the most competitive subspecialties, GI, hemonc, cardiology, pulm crit, but also each year we have residents going into endocrine, rheumatology, nephrology. I'm sure I'm leaving off some, but we do especially well in terms of subspecialty training. Steph, do you want to talk a little bit more about rotation structure?
Yeah, I think like some of the highlights of our program specifically is that UPMC focuses a lot on education. So we are a very strong medical education program. A lot of our faculty trained in medical education. And so we do a lot of teaching throughout the day. We do our morning reports like a lot of other places do, but then we also have afternoon teaching a lot of the time. And we also focus on getting a great balance of resident autonomy. So one of the things that's like one of the most highly rated parts of our program and one of the most unique parts of our program is that we have resident run rounds. And so instead of rounding when you're on the floors as an inpatient doctor, instead of rounding with an attending every day and like kind of presenting to an attending, having the attending kind of dictate plans, you're presenting to your senior resident. The senior resident's leading the team. The attending's not even on rounds with you. So your senior resident makes all of the clinical decision-making for the team for the day. And then after rounds are over, that senior resident then talks to the attending and runs the list with them to make sure that all their plans are on point. But it gives senior residents a ton of autonomy. People really like this. It changes the structure of rounding so that's a lot more relaxed, in my opinion. A lot of participation. It's super nice. The other unique thing about our program is our schedule. We are an X+Y program, meaning that we're 4+4. So for 4 weeks, we're on inpatient rotations on the floors in the ICU on night float. And then the next 4 weeks, we're on an elective or outpatient rotation where you're working a little bit less hours. You're working Monday through Friday. You have all your weekends off. So it's really nice to balance kind of work and life. It gives you a lot of time to do stuff outside of medicine, like we were talking about earlier. And it gives you a lot of time to focus on research during those outpatient blocks too, if you're interested in that.
Oh, thank you so much for that overview. I think we would also love to know more about Pittsburgh. Usually we ask people here what are their favorite place to eat and also favorite place to visit. So I would love to know from all the residents here.
I'm going to put Diago on the spot for this. Since he's one of the newest people to Pittsburgh, I want to hear what he has to say.
This is a very good question. So Pennsylvania Market is a place that I like. It's in a strip. Strip district is a very interesting neighborhood. There are several restaurants and bars there. So it's a very good place to know. If you've never been to Pittsburgh, don't forget to go there and to Mount Washington. There are very good restaurants there and the view is amazing, like amazing. I think this is the best for the food that I've seen there. And Ravi, Ravi asked about Steelers fan. Ravi, I have to be a Steelers fan, man. Pittsburgh is the Steelers. Whatever you go, people talk about it. They are sad if they lose. They are happy if they win. So Steelers everywhere. Everything is black and yellow.
Yeah, agreed. I think that like you were saying, the Steelers are like a huge part of the city. Our patients, like that's one thing that you can ask any patient any time of the day, especially game days or day after game days. It's always something to talk to your patients about. So it's really, really awesome. I think if I could recommend someone like who comes to visit the city, I would say go to one of the sports events here because it's like really awesome to see the city rally around the sports teams here. Everyone's obsessed with the sports team. So you can go to the Pirates games. We're not very good at baseball, but the stadium is beautiful. You have a great view of the city. I would highly recommend going there in the springtime or the summer. And then in the fall, winter, you should absolutely check out the Steeler game. Those are so fun.
Yeah, that sounds amazing. Thank you. And also, since we have those meetings, they are global VMR. So I would love to know more about the International Scholars Track. If maybe Thiago and Raissa can say something to us, to the IMG's community here.
Are you there, Raissa?
Yep, I'm here. I'm happy to talk a little bit about IST. I'm biased because I like having the IST track was one of the main reasons that made me choose UPMC.
We are not hearing you.
No, let me see. Can you hear me now?
Yes.
Okay. So I was saying that I love the IST track, and it was one of the main reasons that made me choose UPMC. So we have bi-weekly meetings, some specific classes about either med ed or research. All of us are foreigners, and we have a lot of support in terms of visa, in terms of, IMG specific stuff if we need. And our meetings are with the research track. So it is, heavy in research, but I feel like we have our own program director, Dr. Topolova, a fantastic person. So I feel like we have a lot of support. If you're not from the city, if you don't know anyone here, it's just a way of like bonding with other people that are going through the same thing, and you just feel a lot of support about being here.
I think we lost Raissa. She's now enjoying her tea.
Yeah. Would you like to compliment with something, Thiago?
Oh yeah, so I'm seeing some questions here. So the IST track, there are so many tracks at UPMC. Stephanie can talk more about it, but there are like geriatrics track, women's health track, global health track, and the core residency is the same. So we just have a few months. We have a lot of electives. I mean, a lot. Even in the first year, have 4 or 5. And some of these electives, they are required for the track. So in my track, the International Scholars track, 3 months are dedicated to research during the 3 years. So if you have another, but these are electives. So the categoricals, they can do research if they want, but they can take other electives if they want to. And then we also have these meetings dedicated to research, as Raissa was talking about. So we are not expected to go back home after residency. We can stay whatever we want to be. And they give us the visa that we want to have. So the first email after the match is, what is the visa that you want? What is the visa that you want to have? What are your goals? So we choose our visa. Of course, it depends on your step 3, because you need step 3 to be on an HE visa. But we are not expected to come back home. We are not expected to be in the US. I would say so I think IST has been there for approximately 20 years now. It started with 3 spots, then increased to 5, and today it's 7. And as far as I can see there in the alumni, for sure, over 90% of them, they are in the US. So most of them, they are in the US. They don't come back to their homes, but you can. Stephanie, I think you can talk more about the tracks.
Yep. So besides that specific track, we are pretty into individualizing training for whatever your interests are. So we have specific tracks that you can join, not just the IST track. There's a research pathway aside from that. There's a women's health track. There's a geriatric track, which I was in. There's a global health track, there's a generalist track. I'm probably missing one, hospitalist track. So basically, like whatever your interests are, if you have one of those interests, you can join one of the tracks. The biggest thing in the track is that there's just extra learning for that specific topic. So for the geriatric track that I was in, every Monday afternoon, we had our own noon conference aside from, the general noon conferences that we usually have, that was focused on geriatric topics. And then I had my own geriatric clinic instead of a regular continuity clinic. So we just kind of tailor your day-to-day to fit in more teaching or whatever sort of track that you're interested in. Each track has its own director. You meet the faculty within that area. You have your own mentors within that area. And you kind of form a bond around these people. So it helps. It's a big program. It's a big, hospital system. So it's nice to have these like smaller groups that you have mentorship and feel like you're a part of a smaller group.
Oh, this is amazing. Thank you. I love how much it's personalized with the electives, with the tracks. That's wonderful. Does anyone else have a question to the group, Okay, I don't think so. And since we are almost at our time, Robbie, would you like to say some final words or reflections? Let's see if he's still here. Thank you so much for being here today. We had an amazing case and discussion, and also to present more about the internal medicine program. We could see how much you feel comfortable and you love the program. So it's amazing to have all that information. So thank you so much. Any final words?
Thanks for having us.
Yeah, thanks so much. I sent the link to the website. There's a lot of information there that we try to keep updated, but if you aren't able to find something there or have any other questions, feel free to reach out to us or Thiago or Heiza. Any of us, we're happy to answer questions.
Oh yeah, I will leave my email here. So and good to see you all again. It's such a pleasure.
Oh, thank you so much for
Heiza left the email here, so I'll do the same. So feel free to contact me for further information.
Okay, amazing. Thank you all. Bye-bye.
Bye.
Bye.